Hi everybody, Ziv Simon here. I'm the creator of SurgicalMaster, the surgical training for dentists. Welcome to another video on aesthetic crown lengthening. And this is part 3 out of 3 videos. In the previous ones, I talked about meeting the patient and understanding their concerns, reaching a diagnosis and a treatment plan, and also how I prepare for the procedure by doing a digital simulation. In this video, I'm going to talk about the actual surgery step by step and how it works and what the challenges were. And you'll get a good idea how to perform this in your own practice with your own patients. Now, our patient had a few concerns. One was that there is too much gingiva showing in her smile. She had excessive gingival display. And also short teeth, which is a function of too much tissue. And she was also concerned with the appearance of the upper lip and the tissue tag, right from underneath, and a dark spot on the buccal tissue of number 9. Now in video number 2, I showed you how to do a digital simulation with Photoshop elements, and I showed you how this is being done on a retracted view photo and on the smile photo. So I hope you found this helpful to you, and hopefully you can do this in your own practices. So my treatment plan is number 1, to remove the excessive tissue on the central and lateral incisors, the actual aesthetic crown lengthening, and that will also create better teeth proportions. In the process, I'll be able to remove the lesion, and the last part of the procedure is to remove the frenum, perform a frenectomy. And I wanted to show you some of the challenges that I'm already anticipating as part of this procedure. Number 1, once we resect the tissue on the teeth, we are very close to the frenum. So if you think about it, this is connecting to the lip. We may get a retraction of the flap. And once we perform the frenectomy, literally we are almost perforating or risking a perforation of the flap. So let's see how this was managed later on. In regards to the lesion, there's always a chance that the initial incision will not encompass the whole lesion, so I may need to go a little bit further, and how will this be managed? And the last part of the procedure, when I remove the frenum, will I be able to avoid a perforation, and how is the suturing done, and how can we do it all together? So there were a few challenges. I was definitely concerned with the risk of flap perforation, and I was concerned with the lesion. Will I be able to do it? And, how do I submit it for pathologic evaluation? And also, what do we do first? What is the first step, and how do I sequence this procedure? So the sequence definitely is to start with the crown lengthening, because that's really the patient's main concern. Number 2, I'll see how we can handle the lesion at the same time. That would be ideal. And only then I'll start with the frenectomy and taking great caution not to perforate the flap. So we start with teeth number 8 and 9. I'm aiming for a 10.5 millimeter length for an 8 millimeter width, because what I'm looking at is not the absolute number of the length of the tooth, but more of the ratio between width and height. And as long as you're in between 75 and 80%, you're doing pretty good. That would be very aesthetic. These are normal teeth proportions. Width to height ratio should be between 75 and 80%. So if you have an 8 millimeter width of a tooth and a 10.5 millimeter, you're around 76, 77%. That's the right range. Another tool that can help you is choose proportion gauge. It looks like a cross. It has a part that you place on the incisal edge of the tooth, and it has those blue, black, and red marking, and also the yellow markings in between. So if you're looking at a tooth and it extends between, let's say, those 2 red marks, it should be as long as the red top mark, and that would give you the ideal teeth proportion. So that's another nice tool, inexpensive tool that you can use during the surgery. It's very, very helpful to me. So I would have this available at the time of surgery. I would place it on the incisal edge and measure and see what is the width between which lines, and then I'll know how much to excise. Now, I think that you need to remember that if you're planning to increase the incisal edge, that proportion gauge will not be as helpful. So you have to remember, you have to take this into account, because you wouldn't want to make any decision and then later on increase the incisal edge. All of a sudden the proportions will be off. So take into account if you are planning to change the incisal edge position. But it's definitely a very helpful tool. So the actual procedure of aesthetic crown lengthening is based on two steps. The first step is the soft tissue excision. We're removing the redundant tissue. And the second step, after you reflected the full thickness flap, is bone recontouring. You're addressing the bone underneath by doing two things. One is ostectomy, which is removing supporting bone, and doing some osteoplasty, removing non-supporting bone, changing the shape of bone. And both are very, very important. So interestingly enough, after I got this patient anesthetized and I looked at the lesion, I decided to place a little probe, a little explorer underneath, and I was able to remove something from underneath the tissue. And as you can see, this was actually not a lesion. It was not a pigmented lesion. It was a foreign body that was stuck in there, some type of food particle. So we already addressed that. So that was a nice surprise for me. So we're moving on to the aesthetic crown lengthening. What I suggest is once you decided where your gingival margin would be, it really helps to create some bleeding points. And the bleeding points will give you an outline how to make the incision. First incision is made between the line angles of the teeth. And you create the bleeding point in such position that this would be the most apical extent of the incision. After that, you make the incision, and it helps to make a secondary incision that is intrasulcular. So we create the gingivectomy with a blade, and incision number 2 is an intrasulcular incision. What you do then, using an Orban knife or a curette, you remove the excessive tissue. So now you have the full clinical crown that was hidden under the gingiva now fully exposed. And this is a very critical part of the procedure. The third incision, you make a secondary intrasulcular incision, because what we'll do next will reflect the full thickness flap. So we need to make sure that we repeat the incision with the number 15 blade. And keep in mind that you'd like to keep the interproximal tissue, the papilla, mostly in between the teeth. We wouldn't want to reflect all the papilla with the flap, because then we're risking losing them and creating, the black triangle problem. Now, in regards to the papilla area, you have a couple of options. You can use a triangular shape that you see right in here, or basically from line angle to line angle. It doesn't make a big difference. This type of incision is a little bit more conservative, because you're preserving more of the tissue. For some of the beginner surgeon, it's easier to do. I prefer the triangular incision because I feel that the suturing is nicer and the tissue blends better, but the choice is yours. So the next step is to reflect the full thickness flap, reflect an elaborate flap so you can visualize the underlying bone. I recommend you reflect it beyond the mucogingival junction so you have good visibility, and also when you get to the osseous recontouring, you'll be able to protect the flap with an elevator and do it very, very comfortably. So what we're going to see next and visualize is identifying the CEJ. It's not always easy, but it's important to look at it, because many times for patients with delayed active eruption, the bone will be at the CEJ level, which is abnormal. It's too incisal. Sometimes even covering the CEJ. So you'll measure and evaluate how much bone excess you have, and then you need to make a decision how much bone you need to remove. We need to remove some bone vertically and some also horizontally by doing osteoplasty. So the biggest question that I'm always asked is how much bone to remove, and that's the part that a lot of dentists get kind of stuck in. So if you think about it, the vertical bone position needs to be 3 millimeters apical to the new free gingival margin. So you need to use a surgical guide or use your proportion gauge or probe to now know where is going to be the new gingival margin, and then you count back 3 millimeters apical to that. That's going to be the new vertical bone position, and that's what you need to do. The reason why it's 3, we need to accommodate the sulcus, which is about 1 millimeter, and about 2 millimeters for the biologic width for the attachment. So keep in mind, this is going to be the new bone position. How do we reduce bone vertically? We have a couple of options. One is to use an end cutting burr. It's called simply the crown lengthening burr. It comes in different sizes. And that's the part where you'll do an ostectomy. That's the part where you're removing supporting bone. But it's also as important to do some horizontal bone reduction, what we call osteoplasty, remove all this bone excess using a round burr or a football-shaped burr. Because if you don't, you may experience a relapse. So both are very, very important. You can also thin out the bone horizontally first and then use some hand instruments to do the rest in terms of the vertical reduction. So we're starting with vertical reduction of bone using rotary instruments and hand instruments. We're reaching a level that is about 3 millimeters apical to the new gingival margin that you're planning, and get to a point where you can create a knife edge from the bone all the way to the root surface, because the gingiva does not like to heal in steps. So if you're using a crown lengthening burr, an end cutting burr, you'll notice that a step is being created. So what you can do then, either with a round diamond burr or with hand instruments, you'll basically smooth out the step and remove it very carefully. Be very cautious not to touch the root surfaces, because you may cause some problems in that regard. So once you're done with the bone reduction, use a lot of saline irrigation. There is going to be a lot of debris and things under the flap that you need to irrigate. And that's pretty much the end of the aesthetic crown lengthening. Now, remember, we have also a frenum to resect. And the way the resection is going to work, we'll start from the part that is attached to the keratinized tissue and basically place our blade in parallel to the attached tissue, and then resect it from the lip end right in here. Now, once you do that, you basically have a pretty large open incision. Okay, so you have to be very careful not to create a perforation right in there, because you're perforating your flap. You can create some necrosis problems, and you know, I wrote down there's a perforation alert. You got to be very, very careful. Be on your toes. So the way we handle that, we will create an incision that is, again, very parallel to the flap. You're basically dealing with pure periosteum right in here. And you can use the blade, the number 15 blade, to create some scoring right here. You'll scar the periosteum, but the flap will still be intact. So you'll use this blade only in the part that is non-attached, that you didn't reflect yet. And this way you'll avoid a perforation. But the perforation risk is always there. You got to be very, very careful. Once you're done with this process, the next part is to suture the flap. So you'll start by suturing the actual flap and suturing the triangular part that you just excised initially to the papilla area that you kept in place. And only then you'll suture the frenum. Now, it may seem like a large opening, but really the tissue is very mobile, very stretchable because of a lot of elastin in the tissue. You'll be able to close it almost primarily in the lip part. So make sure that the flap is stable, that you're controlling the bleeding, and you'll see that a week later, the healing is going to be great. There are very little side effects. Teeth may be a little bit sensitive. There may be slight bleeding in the interproximal tissue. That's the part that heals the last, but it'll definitely heal. And you see within a few weeks, the tissue will heal very, very nicely, and the frenum will present itself with a little scar tissue, and we know that this is not going to reattach again. So in this particular case, the patient healed very well with minimal side effects. Now, I went back and with my proportion gauge, and I wanted to see how I did, and I'm looking at number 9. The width of the tooth is in between those two red lines, and the height of the tooth is all the way to the red line. So we have proper tooth proportion. And how about number 8? I think number 8, I was probably a little bit too shy. I mean, we're looking at we have some tissue that was possibly relapsed. So I'm not 100% symmetrical A possible reason for that is either I was too conservative with the bone reduction or with the initial excision. So you have the option to go back and basically remove a little bit more tissue, a little bit more bone, and get your result even more perfect. But for this patient, she was very happy with the outcome. As we can see, the gingival margin doesn't show to the fullest extent, and she was happy with the result. I didn't go back. So again, it's interesting to see the digital simulation and the actual result not quite the same. And I suggest you do the same thing. Be very critical with your own work. Give yourself some grades, and it's a blessing and a curse. Number one, you'll get better at what you do. Number two, you'll see that not always you're getting the ideal results. But certainly, I was quite pleased with how this case turned out, and the patient's concerns were addressed. So if you're considering aesthetic crown lengthening for your patient, definitely focus on not just the length of the tooth, but the proportion or the ratio between width and height. You have your proportion gauge to help you. Do everything that you can to plan an ideal gingival margin. Use a digital simulation, diagnostic wax up, and a mock-up. These things help, and you were able to see in video number 2 how we do the simulation. And it's really about the incision and flap design and careful management, and being careful not to perforate the flap if you're incorporating a frenectomy at the same time. And also the importance of bone surgery, removing the supporting bone, placing it at the proper level, and also doing osteoplasty, creating the nice knife edge to the root surface. All of these things are important, and if you follow these steps, you ensure that you'll get great result with your crown lengthening procedures. So case is complete. I hope you enjoyed this video series, starting from part 1, where I met the patient, looked at the concerns, and we formulated a treatment plan, to how I prepared for the surgery with a digital simulation, and to the actual process of the surgery and some of the challenges, and I showed you some of the results that I had. And I hope this was very valuable in education for you, so you can help your patients with excessive gingival display with crown lengthening. So I hope you enjoyed this. I hope you keep learning and trying and practicing and stay in the game and keep working at it. And I look forward to seeing you in the future.